Malaria is one of the leading causes of death in Tanzania, and after neonatal causes, it accounts for 23% of all infant deaths under 5. Generally, a lot of Western NGOs assume that if they just educate the mothers about malaria, or if they provide diagnostic equipment like microscopes to the local clinics, then the problem will be solved and the mortality rate will go down. However, this is not necessarily the case because there's a lot of sociocultural, economic, and political factors that go into the treatment of childhood malaria. Mothers in Tanzania generally already know the symptoms of malaria. They know that it's caused by mosquitoes. Some of them can even identify it by the scientific name Plasmodium. The vast majority of the mothers wait at least 48 hours before they bring their febrile child in. So why is this happening? First of all, mothers prefer home treatment, and they do this with aspirin and by sponging the child off to reduce the fever. Now this might be because they know there's going to be a long waiting period at the local clinic, so they want to do something to reduce the severity of their child's fever before they go to the clinic. Studies have found that only between 5 to 16% of mothers will presumptively treat with an anti-malarial before being advised to do so by a local clinic. Part of the answer to this question is likely the perceived severity of the illness as well. Sometimes mothers believe that their child only has an ordinary fever or a virus, and that if they wait it out that the illness will go away. In the local model of the illness starts out with homa, which means fever in Swahili, and then it can progress to homa kali, which is more severe fever, and then if left untreated it can progress to dege or cerebral malaria. Another problem is that when malaria is complicated by convulsions, mothers may choose a different treatment path. They may think that when the child is convulsing, they need to be treated by a traditional healer because they believe that this condition is caused by a spirit that takes the form of a bird and comes and casts its shadow on the child on a moonlit night. Another belief that may hinder the treatment of malaria for these children under 5 is that a lot of the mothers believe that mixing a strong treatment with a strong illness will cause the death of the child. Another problem is communication with the staff. Sometimes the staff will talk down to the mothers, and they can be actually very aggressive when they perceive mothers as taking their child in late. However, usually the reason that the mothers bring their child in late is because they really don't have faith that the clinic has the proper skills or the proper equipment to be able to treat their child. Cost is another factor. Some articles have found that cost is a problem for mothers who want to bring their child to the local clinic, but other articles have found that they only have to pay about 100 Tanzanian shillings, which they regard as their contribution. It's not much more than a bus fee. Another factor is political. The current guidelines in Tanzania are that any child with a fever should be presumptively diagnosed with malaria. So whether or not there are microscopes, whether the microscopes say that the child doesn't have malaria, even if they're slide negative, according to the national policy, they're supposed to diagnose their child with malaria. And this is a problem because the parasites rapidly adapt to medication that is given them. So there's constantly new medications having to be developed, and this is very expensive, and it's also very hard to disseminate, and it becomes more costly for the mothers as well. This can lead to a problem with child deaths being presumed to be malaria when it actually might be pneumonia. So they're not getting the proper medication, and the children may end up dying of pneumonia. So the overdiagnosis of malaria is a very big problem, and this is why some say that getting microscopes into local clinics is a very big deal. However, another problem is that there's extensive training required to be able to correctly read these microscopes, and so this requires a lot more money in addition to just the technology if we want to reduce childhood mortality. Another problem is the time at which the child gets sick. If a child gets sick with severe malaria during the weekends or at nighttime or on a holiday, then the local dispensary will likely be closed, and so the mother has no choice but to either run to a traditional healer or to take their child to the hospital, and the hospital will likely be a couple of hours away, and so she might not even have enough time to get to the hospital before the child dies of malaria. So although most NGOs consider educating the mothers and placing microscopes in local clinics as the main solutions, these might not be sufficient solutions. Rather, solutions might be to help train the staff workers at the clinic, and this could include putting funding into doing rotations with doctors who are in the city, and also to train the Ministry of Health to give more productive, specific, and upbeat feedback when they go to observe the people at these rural clinics.